Hi, Sally. I saw Sally. Great to see you. Ready for the start?
I was just wondering whether the baby's already signed up for NP school.
Good
No,
question.
darling, the baby signed for nursing first.
NP school. I like how you
Well,
put it.
he might already be nursing right now, though.
I was just wondering if I'm going to have the gallery option here. To see everybody.
Yes, you do. We
I
have.
see it.
Yeah, I have to fiddle around with it a little bit.
Yeah, that was why we chose this approach. Now, what it means is that while there is speaking and question period, we each have to be on mute. Otherwise, there can be interference. And our moderators will all remind you of this.
But before I put myself on mute, I'm just going to tell that I'm very happy to see all of you because we missed all the conferences this year, so we didn't see anybody. So I'm very happy to see you all. I don't know if you know me, but I'm very happy to see you all.
Well, this is great. We're happy to see you.
We are happy to see you too, and we will be even happier when we see people in person one day. One day, you know, like the song, one day.
Yeah.
La, 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 la.
Doris, I wanted music.
We should say after COVID.
Yeah.
So 2 minutes and we go. So Arik and others with babies. Let's see if you will match my 5-year-old grandson who invented a song for RNAO without being prompted or asked. And gave me first a card that had all the words of the song and then started to sing it. And I thought, oh gosh, I didn't tape him. That would have been good for a membership promo.
Well, why don't you sing it?
I think we are ready to get going.
Yeah.
Can we start, Doris?
Let's do, please.
Okay, wonderful. Welcome,
Thank you,
everyone.
Catherine.
My pleasure. Welcome, everyone, to the 7th Annual Nurse Practitioner Knowledge Exchange Symposium. This year, we've titled it Moving from Strength to Greater Strength, NPs in Ontario, Canada, and around the globe. We are pleased to have you here today, and I am most pleased to introduce you to our co-hosts for the day, Dr. Doris Grinspun and Sally Berg. Dr. Doris Grinspun is Chief Executive Officer of the Registered Nurses Association of Ontario, the professional association representing RNs, NPs, and nursing students in Canada's most populous province. She is a champion of quality, person-centered care in all nursing students, RNs, and NPs. She is an extraordinary nursing leader, widely recognized at home and abroad. She is a visionary and champion for healthy public policy and evidence-based practice. A force to be reckoned with, Dr. Grinspun has successfully led teams advocating for policy changes that improve patient, organizational, and health system outcomes. Dr. Grinspun is lauded for having transformed nursing and healthcare practice with the introduction of RNAO's best practice guidelines, now considered the gold standard for bringing evidence to the point of care. Grinspun has published more than 250 articles and delivered more than 400 presentations and keynotes to advance nursing, health, and healthcare. The recipient of over 60 awards and investures, Grinspun's national and international acclaim comes from enriching the lives of others and role modeling, speaking out for nursing and for health with evidence and courage. Sally Berg is a nurse practitioner who is currently working in the community, specializing in palliative care in the Niagara area. She is a nursing graduate from McMaster University and a graduate from York University from the Nurse Practitioner program. She holds a Master of Science in Applied Health Sciences from Brock University and a Master of Science in Nursing from York University. Sally has 3 adult children and has been married to her husband for 30 years. Her daughter is now following in her footsteps and is working in the Toronto area as a nurse. Sally is currently actively involved as the chair of RNAO's Nurse Practitioner Interest Group and has been critical in leading its dynamic program. Sally is passionate about the role of the NP and driven to make system changes to ensure that populations benefit from NP's current and potential contributions in practice roles and the many other programs and roles NPs are active in across the health system. So we welcome both Dr. Doris Grinspun and Sally Berg, who will take you through some opening remarks.
Thank you so very much. And a long time that I didn't have such a formal introduction, and I tried to put the stop sign and I couldn't. First of all, it's just so good to be together. That's, I guess, the first overall statement I want to share. The shortfalls of COVID and the hardships of COVID, but the strength of virtual really allows us to be together. In some ways, even more than before, in terms of the reach and the access that people can have and that we all can have. So the goal of today is to yet again push one step further the NP movement, I would say, the movement of nurse practitioners in this country and by extension in other parts of the world. And that's why you will hear from 2 very esteemed colleagues from abroad. My co-chair in the task force, which you will hear from her soon, and then also the head of Nursing Now International. We want to gain knowledge about the Nurse Practitioner Task Force. We will review with you the recommendations. We decided not to release the report today simply because of how busy people are with the second wave of COVID and the circumstances in Ontario and in Canada and abroad, I would say. And because we want to also build side by side a very robust social media campaign that will take the recommendations forward. Let me assure you that we are, as we speak, advancing every single recommendation. Some of you know RNAO and know how we work at RNAO. We don't wait for the report to actually advance the recommendations. In fact, sometimes it's better not to have a report out so the recommendations can move unhindered. So be assured that's happening, and we will continue to do that. That's not to diminish the importance of when the report comes out. It is our view that the report will have a resounding impact, not only in Ontario, where I would say that the NP movement is well and alive and ongoingly being tapped to as a resource for the province. But in other provinces, not in all jurisdictions, is the same. So we do think this will have an impact across Canada and internationally. We want, as much as we share with you and the panel, then we'll discuss the recommendations. We also want to hear from you. We want to share and discuss how clinical policy and governance, the role of MPs during COVID has impacted the nurse practitioner role and movement, and if it does not, how it should impact the nurse practitioner role and movement. Some activities that during COVID have been under emergency orders perhaps should become, hint, hint, permanent features of what MPs can do. Equally important is we want to know, after you hear from the panel, there will be time for discussion and questions. Next one, please. Next slide, please, Catherine. We want to know if you feel that those are the key recommendations. And if at any point you feel that we are missing one or missing something, don't shy away, write it in your chat, and or just put your hand sign up and let us know. And we want to identify opportunities and strategies to enable and advance the full NP role. In Ontario and in Canada, we are deficient, I would say, in the number of NPs per capita if you compare it, for example, to the US, and we will speak about that, and that's part of our recommendations. The utilization of NPs can be further enhanced and enriched and stretched, and there should be a scope expansion, as you just heard between the lines that I just said before. We want to gain new insights on global and local policies impacting health system transformation, and within that, the role of NPs. For example, all the transformation in Ontario of Ontario health teams. What's the role of NPs, not only within sectors, but also within health systems of care. And we want to continue to develop a vibrant public education campaign regarding the role and capacity of nurse practitioners, including NP. And that is where we will need Arik and other babies help to help us make the necessary in-depth noise that will be needed to really push not only the next stretch for NPs in Ontario and elsewhere, but also for the next years to come. I think with that, next slide, please. With that, I want to give to Sally. Sally, would you please review the agenda with us?
Yes, so we have an exciting day today, and it's amazing how we can fill a full day and do it virtually. I'm not sure if you can see that those slides, but feel free to go on to the RNAO website, and you actually can print that off if you want to be able to look at that a little bit easier. But after the opening remarks, we're going to be enjoying more information about the task force and the work that they've done, and looking forward into their vision for tomorrow. And remember, those are the voices of our colleagues, and it's really exciting to showcase the task force work today. We will be breaking then, and then also looking at just information around NP practice and envisioning a future, not just locally, but also globally. Be sure to select one of your concurrent sessions at, sorry, I'm jumping ahead. We do have a lunch and learn session as well that you're welcome to join us with. And those will be, the topics will be presented by some of the task force members, so you'll be able to hear from them firsthand. And then the concurrent sessions, sorry, there's two that we have available to us. The one is more focused on the COVID and the perspectives from acute care and working with Indigenous populations. And then the second concurrent session is about experiences that we've learned from COVID-19, specifically around academia and the mental health and addictions. Then further that, we will have a break and focus on two more items, sorry, the NPs and health system transformation. And that's kind of looking into the future. And the moderator for that will be Doris, and Helen Angus will be joining us, the Deputy Minister of Health, for that session. We'll also be able to, at 3 o'clock, enjoy the Crafting a Courageous Global to Local Public Education campaign. And we're going to have an opportunity to brainstorm there. So I hope you do join us for that. It is the last session of the day, and sometimes people get a little tired, but certainly we want to hear your voices, especially at that session. And then we'll be having our closing remarks and closing by the end of the day for 4 o'clock. So I hope that most of you can join us. I'm looking at the number of participants now, and I'm really excited. We're at 101. I'm seeing it increasing. So it's fantastic. So any of you that have missed, you haven't missed a lot of stuff by joining in at this point. Again, feel free to follow the agenda and make sure that you connect with us if you're not able to connect all day. Next slide. So some overview information that I just wanted to focus on. We're in a meeting format, so that means each of us can see each other. You can click different items in Zoom to be able to see more people, see the screen. I know I will be watching the chats most of the time to try and answer questions and see if there's any questions that might be missed along the way. I know we've got Catherine helping us with that as well. But it does mean that you have to be sure to have your microphone off as well while you're connecting with us, so that we don't have too much feedback and disruption for other people. And then we are recording these sessions, so if you happen to have to step away, please make sure that you're able to connect with the sessions afterwards. I have already mentioned our agenda a little bit more in detail, so I'll skip those items on this slide. Following each session and at the end of the symposium, we will use the polling function to enable you to give feedback. And this is really important for us. It'll help guide us on future symposiums as to how we can do better. And this, of course, is the first symposium that we've done virtually. So we've got a lot of learning to do and are eager for your feedback. The big part of all of this, I want everyone to know, is this is your symposium. This is a compilation of all of us NPs with the great support from RNAO. And I just want you to enjoy the day and also feel free to contribute to many different avenues that we have to allowing your voice to be heard. I want to just quickly also thank everyone that is part of making this day possible. RNAO has been such a backbone to all of this. I almost feel privileged and spoiled as an NP working in the executive. They always say many hands make light work, and seriously, that's exactly what it is today. Catherine, you've been great at helping with the slides, and I know there's many other people contributing to that, but I can't say how much thanks that I have in my heart to all the support. Irma Jean, you've been there in all the emailing and making sure that everything's sort of on key, and also following the RNAO spirit. And Doris, I want to especially thank you for the privilege to have you participate with us today as well. And you will see many people contributing to the sessions as we move forward. And I want to thank all of you ahead of time for your time and effort and being present to share with us.
Wonderful. Thank you so much, Sally. So we will now move on to our opening session.
Maybe we can ask Catherine for people to mute the mics unless they're presenting. That's great.
Yes, please. Okay. And is everyone able to see my new screen that I have shared?
Yes, we can. If you can put it larger, maybe that would be great.
Let me try here, Doris. I'm going to advance to the next slide, and then we'll see if I can adjust the sizing.
Fantastic.
So I'm going to start with introductions. I have given Doris's introduction already. As you know, she is RNAO's CEO, and she is the co-chair of the Nurse Practitioner Task Force. She has brought her passion for NP's role in transformed health system and her long-standing impact on the expanding scope of NPs to this wonderful task force. She is joined today for the opening panel session by her co-chair, Dr. Elissa Ladd. Dr. Ladd received her undergraduate degree from the University of Pennsylvania, Master of Science degree from Rush University, and PhD from the University of Massachusetts. She has worked as a nurse in healthcare settings around the world in volunteer roles, as well as governance and policy roles. Her global work continued within the context of her academic career as a consultant in the development of nurse practitioner program at Walter Sisulu University in South Africa, and as a Fulbright scholar at Manipal University in South India, where at the School of Nursing, she engaged as a faculty member and facilitated partnerships to create a sustained program of support for students. Dr. Ladd's research focuses on practice and policies that pertain to nurse prescribing in domestic and global arenas, and she has lectured and published widely on related policy topics, including advanced practice nursing. She, a member of the core steering group of the International Council of Nurses Practice Nurse Network, is recently appointed a co-director of its Global Academy of Research and Enterprise. Dr. Ladd is a fellow of the American Academy of Nursing, and in 2019 was a recipient of the Inspiring Global Nurse Award by Nurses with Global Impact at the United Nations. We also have a very wonderful speaker today, Barbara Stillwell. She is bringing to us an international perspective. Barbara Stillwell took up the post of Executive Director of the Global Nursing Now campaign in July of 2018. Prior to this, she was Senior Director for Human Resources Solutions at IntraHealth International, based in Chapel Hill, USA. For the past 25 years, Stillwell has worked on international health workforce issues, first with the World Health Organization based in Geneva, and then with IntraHealth International. At the World Health Organization, Stillwell helped change the organization's approaches to performance improvement and served as the focal point on the migration of health workers, negotiating with ministers of health on strategies to address health worker migration. Barbara has helped countries around the world to manage change and development in their own health workforces. In the UK, Stillwell is best known for introducing the nurse practitioner role in general practice. With her international perspective and experience and success with the NP role in the UK, Dr. Stillwell has agreed to share her perspectives and comments on this panel. As you know, she is our featured speaker in the next session, Breaking the Ceiling, related to NP practice. This panel is also featuring some of our many wonderful NP task force members. So we have Vicki, Smye, Beth, Sweeney, and Michelle Acorn. Vicki Smye is an associate professor and director of the Arthur Labatt Family School of Nursing at Western University. There, she maintains a vigorous research program. The goal of her research is to promote health equity, focused in the areas of mental health and Indigenous health. Dr. Smye's program of research includes studies of the health narratives of Indigenous women and men, an examination of those factors that both facilitate and challenge people's abilities to access equitable, safe, and effective healthcare. Currently, she is studying how to promote equity-oriented mental health care, including cultural safety, harm reduction, trauma and violence-informed care, and recovery-oriented approaches within and between mental health institutions and community agencies. Vicki has many years of experience on boards, committees, and task force. As an advocate for health equity and in the educational sphere, she has been a champion for advanced nursing practice and transformational change in education, clinical practice, research, and policy. Vicki is a member and chair of the board of the Ontario Primary Healthcare Nurse Practitioner Program and a board member of the Canadian Association of Schools of Nursing. Vicki is a member of the NP task force and made contributions on her rich knowledge about cultural safety and harm reduction, as well as other related themes of her research program. This was invaluable in helping us to shape recommendations specifically around NP education. Beth Sweeney is a two-time graduate from the University of Toronto, her BSCN in 1992, and was a student of the inaugural Primary Healthcare Nurse Practitioner Coupon Program in 1995. Beth graduated from that program in 1996. Since graduation, she has been involved in the Primary Healthcare Nurse Practitioner Coupon Program as a member of the Curriculum Committee, a tutor, liaison, and now preceptor from University of Western Ontario. Beth has always worked to full scope in NP roles, and she is engaged in adjusting her practice accordingly with legislative and regulatory changes. She is an ardent activist for NP practice and participates in advocacy at all levels. Beth works as a primary healthcare nurse practitioner, both with the Thames Valley Family Health Team and the Craigwood Youth Services Program. She also has a passion for healthy nutrition, exercise, friends, and family. Beth also works part-time as an NP policy consultant at RNAO. Beth has been active on the NP task force, in particular related to advancing policy and practices that ensure all insurance benefit carriers and other such payers will accept nurse practitioner services analogous to physician counterparts, and we'll hear a bit more about that soon. Michelle Acorn. Dr. Acorn's diverse career has evolved from diploma to doctoral education. She is dually certified as both a primary healthcare and adult nurse practitioner and holds emergency and gerontology certifications. Michelle has innovated geriatric assessment and intervention networks and pioneered, researched, and published on the most responsible provider, MRP, impacts of the NP-led model of inpatient hospital care. Michelle transitioned to executive leadership practice, modernizing the Provincial Chief Nursing Officer role in 2018, with a mandate to provide strategic expertise as the technical and clinical advisor. Her scholarship and knowledge translation are in textbooks, peer-reviewed articles, evidence-informed toolkits, and quality improvement initiatives. She is recognized for her mentorship, preceptorship, and teaching. Dr. Acorn is an inaugural fellow of the Canadian Academy of Nursing. She is currently an inaugural International Miller Foundation postdoctoral System Chief Nurse Executive Fellow in the Shaughnessy Nurse Leadership Academy at Case Western Reserve University, as well as at the Canadian Foundation for Healthcare Improvement Extra Executive Team Fellow. Michelle is an active member of the NP Task Force, bringing a practice management and policy perspective to all of the deliberations and as well to shaping the recommendations. So without further ado, we will start the panel and I will be moderating the session. My name is Jewell and I am a nursing policy analyst at RNAO. So pleased to get started.
So first of all, I will start by saying that Jewell is a star. Let me start there. I think I am adding to Sally's comments. But truly, Catherine, every time I hear you, whether it is at a submission, a public event, or this, kudos to you. Fantastic and so seamless and just perfect. Sorry, guys, I do pride. We have tremendous staff and young talent that is beyond belief. So let me share, and Catherine, stop me when I am going to the next person presentation, just in case, because I cannot see the slides too well, they're small. So first objectives, the objectives for this session, so that you know. To share with you about the NP Task Force. You may remember that this started a year ago at the AGM, that I stood up there and I said, we are launching a task force, and Andrea was there. Andrea now is a mother of a beautiful baby, and then Catherine took over Andrea, so I do want to acknowledge that as well. And we set up to first develop a panel that will be would be representative of NPs in all sectors, in all roles, in all regions of the province. And then we thought it will be really important to bring someone that can bring also the international perspective. And this is how we went to our co-chair, who actually leads, as you heard, the work on NPs and advanced practice at ICN. We wanted to understand and gain an overview of what's happening with NPs, and Andrea did a fantastic work with really a environmental scan of every single thing NPs do in Ontario. And one of the striking findings, not different than when we look at RNs or other roles, is that in some sectors they could do A, but then in another sector they couldn't. So something was not gelling in terms of really utilizing NPs to the fullest of their scope. And then we did also systematic review of literature, and then of course the panelists brought to bear what does it mean? What does it mean really, and where do we go with all of that? And this is how we came with 8 recommendations that we believe are, if not groundbreaking, very important. Some of them should have been happening in full already, but what are the hurdles that are not happening is really what's at stake here. We want to ensure that the actions for all of these recommendations enable their fullest implementation, and that we can all rally behind, whether it is people in academia, whether it is in people in clinical practice, in policy, in research, and that this will have repercussion also for the public. Because at the end of the day, the role of the MP, as the role of nurses in general, doesn't exist for the sake of the role itself. It exists so that we can ensure that the public has access to safe and quality and timely healthcare services wherever they live, not just in one place in Ontario and then on the other not. And then we will review with you now those recommendations. Next one, please. So here I went ahead of myself. Here is Andrea, and here is the previous chair of NPIG, who also is a mom. My gosh, maybe everybody that gets involved with us in the MP task in NPIG has a baby, but here you go. So I already mentioned this, so we will go to the next one, please. Next one, please. Next slide, Catherine.
I've advanced the slides, Doris. Are you able to see the methodology and process slide?
You know what? We are not on the same slide. Here you go, because I can see that. Yes, I do. Thank you so much. I was looking at the slide with the picture of Andrea because I put the slides in my machine so I can look at them bigger. Here you go. We'll not do that. We'll only look at this. Thank you so much, Catherine. Apologies. So we identified the stakeholders, as I mentioned. We did the environmental scan. We did consultation several times. We did consultation with the task force and with others to make sure that we had left no stone unturned and no gaps. We look at thematic literature scan, and then we deliberated with the task force. And perhaps the recommendation that had the most deliberation, not surprising because it's new and you will see it later on, is about health systems of care versus individual sectors. And that was the recommendation of the role of NPs in OHTs. And that recommendation is the one probably where we really dig deeper and deeper until we found, so what's the difference between an NP in public health, for example, versus an NP across all the health system. Next one, please. Thank you. We did consultation with NPs in several times, not only once. And we also brought the recommendations to the NP Symposium in 2019, as well as to various meetings, including to the board of directors of RNAO. Thank you. Things virtual. To speak a bit about the model. So there were two, not competing, but two actually more than complementary, two very foundational models that we use for the NPIC task force. The first one is the quadruple aim. You may remember that the quadruple aim is being used all the time when we speak about health system transformation in Ontario and in other health systems that are across all sectors. So I'm referring about the health system in Ontario, but also specifically the Ontario health teams. Within the quadruple aim, as you know, we have 4 quadrants, and it speaks about the person-centered care, the experience of persons, or what we call patients or clients, depending on where they graduate to a title, but the people that actually nurse practitioners serve. We also looked at the value, meaning the clinical outcomes and the result of those clinical outcomes. So those are two of the other segments of the quadruple aim. Clinical outcomes that if you, for example, practice with evidence-based practice, you will decrease, right, complications. You will have less falls. You will have less other type of complications, for example, infections in the case of specifically the role of NPs. You will have a decrease obesity if we tackle issues of social determinants of health, etc. And if you have that, you will have better value for money, meaning you will decrease the cost of the system because you will be saving on what we call good savings at RNAO. Good savings means savings that do not relate to cutting health human resources, but relate to actually cutting complications for persons that either wait too long for care or receive care that is not evidence-based. And as you may know, this used to be called the triple aim. And what happened is that a few disturbers of the status quo, some of us included, started to say a few years ago that the triple aim was insufficient because you couldn't deliver really on those three aims of better experience for patients, better clinical care, and better health outcomes, therefore, and better value for money because of less complications, unless you have a very engaged workforce. And the engaged workforce, of course, is what's the fourth aim in the quadruple aim, which means meaningful work with people that are fully engaged in their work. This is, by the way, the work that RNAO is doing as we speak with Ontario Health Teams. We then layer on that, and I do want to credit our co-chair of the task force, Elissa, because we did layer into that, and that's the framework that she had used at ICN, the sustainable goal, development goals, the SDGs. And we said, and as you remember, the sustainable goals speak all about the environment, social determinants of health, no poverty, etc., etc. And of course, that's the foundation for good health for people, where the quadruple aim is more the foundation of a healthcare system, right? So one is the foundation for a healthy society, and within that is the foundation for a healthcare system. And quite simply, you cannot truly, this is what we claim in the report, we cannot truly deliver on the quadruple aim if we don't tackle at the same time the Sustainable Development Goals, which is the foundation for a healthy society. So that's the play that we have within both foundational models. And this is why it's not that they are at all at odds with one another or in tension with one another, but quite the opposite. One is, so to speak, more internal to the other. And you can see that around those, all those colors around are the social, the Sustainable Development Goals, right? So that's exactly the number of Sustainable Development Goals. And inside is the quadruple aim that if you see those separate, you will see the list of all the Sustainable Development Goals in all those beautiful colors, each one of them. And inside that is the quadruple aim that I just mentioned before. That's to explain you the overall blueprint of two complementary models and models that cannot work, especially the quadruple aim, cannot work in the absence of sustainable of attention to Sustainable Development Goals. Next one, please. And so I will ask now my co-chair to please share the objectives of the task force and all the recommendations. But if you may, first share with us, what did it mean? Because I remember our first conversation when I gave you a call if we could talk about you joining our task force. And very astutely you said, why me and what for? And I wonder if almost, well, not almost, a year after, what are your thoughts? I remembered also vividly, our colleagues come from the US, some of the discussions where she was asking things that really for us were so natural, like universal access to care. And yet, because the US is so different, it really pushed us to think hard. For example, sure is universal access to care, but how about the fact that MPs do not get reimbursed by insurance companies when the service doesn't fall under the basket of universal care? And we would not have had the same push if we didn't have that perspective from a reality that is very different than others. So first of all, I want to say thank you for joining and agreeing to join as a co-chair, not only today as co-chair. And if you can give us both your reflections and also the objectives and the recommendations. Thank you.
Thanks so much, Doris. And it's really exciting to be here after I was just counting about 15 months of work, right, Doris, when we first started chatting about this. So I just wanted to, before we get started, I just wanted to give kind of some comments and thoughts about the processes and kind of similarities and differences between, in terms of our practice as nurse practitioners. But before I do that, I did want to make a few comments about the ICN, Advanced Practice Nurse Network, that I've been involved with for the past 5 or so years. And I just did want to say that this is an amazing organization that's really been involved in building capacity for advanced practice nursing since its official inception about in the year 2000. There was a lot of work that was going on before that, but that was kind of more of their official start. And they've primarily been involved in advocacy, research, and the development of and support of educational standards for nurse practitioners around the world. Also, the ICN Advanced Practice Network supports the ICN to more effectively meet its mandate as the global voice of nurses, especially nurses in advanced roles, like all of us. So the ICN is really the global voice. And I would like to say also that this global voice is really growing in volume and breadth as nations around the world move towards universal health care, and they seek solutions for, to increasing demand and unmet needs that are, especially in light of the global challenges around COVID-19. So that's a little bit about just kind of ICN, APN network background. And now the kind of the fun part, I've really been thinking about this. In terms of just, I wanted to share my thoughts about the process that Doris and the RNAO have undertaken over the past 15 months or so, and a little bit, I would say, my thoughts on the NP role in Canada, but again, from an American lens. So first of all, of course, we know, as with everything, there are similarities and differences in terms of role and practices. And let me just kind of highlight some of those, because sometimes we, I guess when we look at other people, when then we kind of, other people help us reflect on ourselves. So just in terms of similarities, I would say, you know, really our day-to-day role and practice is very, very similar. Our educational standards are very similar. We're educated at the very minimum at a master's degree. And again, that's what the ICN Advanced Practice Network really recommends for nurse practitioners around the world. We all also, I would say, face challenges around role acceptance by some factions, I would say by organized medicine. That's certainly something that we have dealt with for the past 40 years or so. It has gotten a lot better, but still something very much a part of our lives, our everyday lives. We all face challenges around compensation And I would say some aspects of scope of practice. However, and I think the scope of practice issues that you're facing, as well as our challenges, while they're a little bit different, we certainly address those, I would say, on a day-to-day basis. And these scope of practice issues I think, that are challenges that NPs face around the world. So a little bit about our differences. I would say that the trajectory and slope of your role development has really accelerated very rapidly since the early 1990s, probably as a result of your healthcare reform and increasing demand in your country for primary care. Hello?
You're good, Elissa.
Oh, okay.
Can we,
Okay, thank you. I heard you. Thank you. Also in contrast, in the United States, we've had a kind of a more slow yet steady pace of integration into our health system, even in the face of our early and robust opposition to the role. Our numbers, probably because over a 30-year history and also the size of our population here, are larger. According to one study that was published in 2016 by Meyer, so nurse practitioners were about 6% of the nursing workforce in the United States compared to 1.5% in Canada. But you're quickly accelerating, I would like to say.
not quickly enough, Elissa.
Okay.
Elissa, I just looked at the numbers the other day in the US, I believe over 300,000. Not even
yes,
really quickly. We need to catch up to you urgent.
Right. So, exactly. So we have accelerated, especially, I would say, in the past 10 to 15 years because of an acceleration of NP training programs here in the US. I would like to say, unlike the United States, you have been greatly supported in terms of your scope of practice, both by your provincial governmental systems as well as the federal government. That's very, very different than the United States. We have a more extensive system of kind of patchwork regulations with less than 1/2 of our states that allow full practice authority. As you know, you pretty much across the board have full practice authority in all provinces in Canada. And so when you think about it, we've been working at this a lot longer and we're still not there yet. We still have a lot of work to do. While our federal government government's really offered us very minimal support compared to yours that has supported you. Just recently, our Veterans Administration actually is the first governmental organization that actually supported full scope NP practice. I would like I would like to point out also one of the major differences in terms of our two countries, of course, is the financing and the organization of our healthcare systems. You have what is called a single payer system, universal healthcare, where all citizens have some level of access to healthcare services. In contrast, our system, as you're probably aware, is very expensive, does not cover our citizens for basic healthcare services, unfortunately. So I would say while we do a very good job at developing innovative technologies and treatment, that development of those technologies comes at a very, very steep cost. And I would argue it leaves some people behind in terms of accessing essential services. The focus also, this financing focus and the cost of our system, importantly in terms of nurse practitioner practice, has led to a lot of very good research about cost effectiveness of nurse practitioners. The predominant theme of a lot of this research that's been done here in the United States has found that NPs are more cost effective than physician care. However, I really want to point out this point, the margin is not very large. That being said, so we have been found to be more cost effective. However, I do think personally that we could be doing a lot better because again, in our system, cost is really the biggest driver. And I would say from a Canadian perspective, this is probably one area of opportunity that you have in terms of robust nurse practitioner research, as your system, like all systems around the world, are really grappling with expanding access and importantly, improving efficiencies. And I think that's probably your next step kind of down this road of kind of building a robust research trajectory for your profession. Finally, last but not least, I just wanted to say after this whole process, I really think this has been a tremendous honor to participate in this provincial level of analysis of NP practice, along with the development of recommendations that we're going to be talking about today. There's been tremendous amount of work that's gone into this, and I cannot, I would say, I cannot neglect to note the tremendous leadership and laser focus of Doris Grinspun. I met her at that meeting that Doris was talking about last February, and it was very clear to me. My impression that is it was a true force of nature and actually a real treasure for the nursing profession in Ontario. So it was wonderful to meet you, Doris. And I also would like to say you all are really lucky. She is justly your greatest advocate. And I think that you're really fortunate to have her as your guide and your leader. So with that, I will turn it over to our next section, and we're going to be going over the recommendations. Isn't that correct, Doris?
Yes, thank you very much for your kind words, Elissa. And I noticed that some mentioned the Academy. I think Michelle had in her bio the Academy. So 2 things about the Academy. I do want to acknowledge that Dr. Irma-Jean Bainok, who is with us today, and myself, but more importantly, 18 RNAO members were introduced to the Canadian Academy, and Dr. Elissa Labatt was introduced this year to the American Academy of Nurses. So kudos to you.
Thank you.
So we will be talking now about the recommendations, and we will be speaking about all of them, starting with the issue of increased supply. And it's interesting, but because now that I heard you once again, but every time each of us speaks, we bring different reflections, Elissa. It just dawned on me because I'm speaking about the increase in supply that we need. And during the NP Nursing Week, it came across to me a fantastic TikTok that the American NP Association had done about NPs. And that's where I learned about the 300,000 NPs in the US. But it just dawned on me, one thing that you said, and you put it a bit as a, maybe it's not so good. And I now I'm thinking maybe actually it has a plus. This issue that in the US, everything is decentralized. You know, it's the same problem with the US about baccalaureate entry to practice. We are much smaller and much tighter, and therefore we can move things faster. However, maybe because it is decentralized, some jurisdictions in the US can go faster and be go-getters. Like I saw some of the healthcare organizations in the US in one unit in a hospital, they have 50 NPs in one unit, right? So there are, I think it's interesting to do, and perhaps we will augment the analysis of the task force on that, the plus and minuses of being centralized versus decentralized. Because you mentioned one of our, sometimes ally and sometimes not so ally, our colleagues in medicine. Perhaps when it's decentralized, they have less control of stopping something than when it's centralized. Who knows, right? But the issue of supply of nurse practitioners in Canada overall and in Ontario is a serious issue, because we keep speaking about the fact that people don't have enough timely access to safe and quality services wherever they are. And the reality is that there is no good reason for it, because not only we can have double and triple the number of NPs if the province or the country needed that, but more importantly, we need that. So within that, we're talking about increasing the supply of nurse practitioners by government developing not just a go and stop or stop and go, depending on who is pushing government approach, which is what's going on now. So you saw that many of us pushed, and I want to also credit on that Michelle Acorn, because Michelle has worked in correctional facilities, and she also mentioned at our task force the issue of correctional facilities, and many of us pushed also directly with government about that, and now it's being implemented. Hence, Sally, why I said, don't worry that we have an issue, the report, we're pushing the recommendations anyways. But it's still, right, it's an approach of the way, what I spoke with government, COVID, there will be COVID second wave. And we spoke even in the first wave, and it will be a disaster in correctional facilities, and you need to have the right people to look after inmates, etc., etc., etc. And now we have a program between all of us pushing. What we need is a comprehensive health human resources plan where NPs are a critical foundation to a system that is yearning for better access across all corners in this province and in fact in the country. So that's the first recommendation. And for that, we need to increase the funding and capacity of seat in nurse practitioner educational programs. But the reality is that what we need to push first is government to ensure that nurse practitioners are in every corner of the province, as you have heard us do publicly in the media and also publicly with government in the basic care guarantee for nursing homes, where we are asking one nurse practitioner per 120 residents. And we have been asking that for at least 6 years. And stay tuned, because I do believe that we will gain a huge, huge, huge traction there. Some of my colleagues here were with me when I presented to the commissioner twice and a third time this past week. Please be attentive that it is critical to counter when you hear we don't have enough, we cannot have the 1 per 120, we don't have enough with the specialty. Forget, please, the word we don't and move to the word we do. Because, and that will come in the last session of today, one of the key messages is a yes, we can attitude. Because sometimes we are worse enemies to ourselves when we start to say, well, but we don't have enough with the specialty in gerontology. Well, but we don't have enough. We do, and we can. That's the message, because that's what the public needs. Next one, please, Catherine. Thank you.
Wonderful. Thank you, Doris. And I'm going to pass it over to Michelle Acorn now, who's going to speak to recommendation 2 and 3. Thank you.
Great. Good morning, everybody. Thank you, Doris, as well. And I'd like to hope that everybody had a great Nurse Practitioner Week. It was wonderful engaging with you all. And again, thank you, Sally, Catherine, as well. As you know, nurse practitioners are valued members of the health system, and the government continues to support utilization of nurse practitioners in the Ontario health system. As the Provincial Chief Nursing Officer, I'd like to have permission today to actually be an active member of RNAO, to be authentic, and to share with you today as a nurse practitioner student in a postdoctorate some systems and transformation, if that's okay with everybody. So first thing is actually utilization. If we want to be authentic and advance momentum for nurse practitioners, we need to really think about utilization and model and be champions of what that looks like. And what is true optimization? Is that on a personal nurse practitioner stance. I'm a primary care NP and I'm an adult nurse practitioner, and I'm also a doctor of nurse practitioner. So when I think about utilizing it in the current state and the current realities, full utilization is across the entire healthcare system and sectors. So also utilization is not just as clinicians, direct care providers, it's actually the advanced practice domains. And what that utilization is in terms of leadership, research, education, collaboration, and quality improvement. But more importantly, do others know in terms of your leaders and your organizations what your utilization is? Some things are very visible to people and some things are not. So we really need to catapult what our utilization is, and not just in terms of data as well. If COVID-19 has not taught us anything, it has shown how we are disruptive innovators. It's shown how we are responsive, flexible, portable across the entire healthcare system. So our utilization should not be geography bound. And when I think about that, it's not geography bound in terms of local, provincial, national, or global. We should be able to pivot and flow in between in terms of transforming what a healthcare system truly looks like. And more importantly, I think Doris highlighted on that quadruple aim. And part of that is the fourth aim, and what that speaks to is clinician wellness and how we support nurse practitioners, our interprofessional teams, and our leaders as well for sustained utilization. Our current realities have also taught us the value add and how we can be responsive, and we don't want geography specifically defining true utilization or integration. So we can talk about Ontario health teams and what that looks like. The intersection with primary health care, whether it's community health centers, nurse practitioner-led clinics, family health teams, Aboriginal health centers, for example. Where do we actually, where does retirement homes fit into this? Right now, COVID has taught us it's not just long-term care, it's retirement home sectors. Then, for example, long-term care homes. And when we talk about the utilization of nurse practitioners, we need to really model full collaboration between nurse practitioners to support the systems. For example, nurse-led outreach teams and the partnering with the attending nurse practitioner programs is paramount. And look at that collective strength, and more importantly, how we continue to role model, mentor, and help systems, department, hospital, acute care, and the interface with our home and community care as well. We obviously have our 25 MP-led clinics that are showing the importance of nurse practitioner contributions, of course, embedded within the interprofessional teams, but that clinical lead, the leadership, and the governance piece to ensure nurse practitioners are at the decision-making tables, part of the conversations, part of decision-making, and how do we influence policy as well. Then I actually want to move into full utilization in all the systems. How we think about utilization in terms of all our domains and contributions of practice need to be articulated about how we contribute to direct patient care, whether we are doing that ourselves as clinicians or supporting others, and what our roles look like in terms of leaders or educators in supporting direct patient care as well. Doris mentioned earlier the correctional interface. And I really think it's important that we think about the correctional institutions. We have 25 across Ontario, just like the MP-led clinics, by the way. And we need to think about transforming and transitions in care. It should be seamless, no matter whether it's primary care and correctional care. So how are we utilizing our nurse practitioners to their fullest potential? In terms of the third recommendation is expanding the scope of practice. Scope of practice can be defined in many different ways, but I think we need to think about competence. We have entry-level competencies as nurse practitioners. Then as we continue for Benner's or Dreyfus's model from novice to expert, how we continue to build those competencies and leverage them in all the advanced practice domains, how we actually are contributing to full scope of practice and capturing the data, for example, as most responsible provider, whether it's in a regardless of the setting, in inpatient or outpatient sectors, are also important. Most recently, I talked to you about being a postdoc fellow and international as well, and it's really made me think about the global context. And I want to now kind of talk to what's happening on a pan-Canadian level. And Elissa talked about earlier the United States and how fortunate we are in Canada and how far we've come. But I'm co-chair of PNAF, which is the Principal Nursing Advisors Task Force. And we have developed a vision for nursing and a work plan moving forward, which actually aligns with some of the recommendations from RNAO and the task force. The vision for nursing looks at the interdependent areas of nursing regulation, education, and scope of practice. So when we're looking at, for example, scope of practice, that actually is across pan-Canadian, all the provinces and territories, and we want it to be harmonized so that wherever we work, that knowledge set is portable and we know for role clarity of what that looks like as well. I'm mindful of the time, but I really have reflected and think as a nurse practitioner, my top 10 transformation leadership attributes, because this is the International Year of the Nurse. I think it's really important that we leverage that leadership capacity. And my first is leadership, vision, and purpose to drive direction and influence, and support it to the full finish line, because you have to be prepared to know what mountain to die on and how to climb up that mountain and keep that sustainable momentum as that climb gets challenging at times. Be deliberate and engaging in strengthening your diverse relationships, networks, and connections outside of nursing as well, across provinces and territories and globally. Leverage your brand. Our brand as nurse practitioner, or whatever you may practice in, even if it's NP, leadership, executive practice. Brand it and marry your knowledge to influence and convince. Target quality, safety, and improvement transparency with meaningful measures. Be authentic, inspiration, trusted, courageous, and flexible in your leadership. Embed your best evidence-informed service, balancing economic stewardship in this day and time. Uphold your professional, ethical, cultural values to optimize your emotional intelligence. Lead agility, span the boundaries for scope and integration, and navigate your systems. Recognize and enable the spread of empowered teams, including nurse practitioners and your patients and your community partners. And lastly, model continuous learning and shape mentorship for optimal nurse practitioner workforce optimization. Thank you.
Thank you, Michelle. We'll move on now to recommendation 3. Or sorry, recommendation 2.1. Michelle, would you like to speak to this?
Actually, I think we can move on to Vicki's. We can highlight those, but I did speak to most of those in my talk to try to not read the slides. I hope I captured it well. If I didn't, feel free to add in, Doris, or others.
No problem. We'll move on now to recommendation 3.0, which is relating to expanding the scope of practice for nurse practitioners. And Michelle, I know you had actually spoken to this already, so if you feel comfortable, we'll move on to 4.
Yes, thanks, Catherine.
Pleasure. Okay, Vicki, please take it away.
Apologies, I wasn't watching the slides. I was just being authentic and speaking.
That's okay, no worries at all.
Anyway, thanks so much for inviting me to speak about the task force work and for your kind introduction, Catherine. It has been a real privilege and pleasure to be part of the work. And in particular, I'm drawing attention to the importance of the alignment of the nurse practitioner curriculum with an expanding scope of practice. So recommendation number 4. First, I'd like to speak from the belief and position. I do speak from the belief and position that primary health care is both an approach and a hallmark of excellence in nursing practice and in all areas of practice, and that health equity is the social mandate of nursing for the 21st century. That is my declared bias. I am a champion for evidence-informed, equity-oriented healthcare. And so there are 4 main activities that are part and parcel of recommendation number 4, and that is the academic, professional, practice partner collaboration, including community engagement with newcomer and Indigenous agencies, centers, programs, etc. as part of that. The second one would be ongoing curriculum mapping and integration of key concepts and new competencies as the scope of practice shifts. So alignment with a number of agencies in Canada, nursing agencies in Canada, but particularly with the regulatory and approval body here in Ontario, that's the College of Nurses of Ontario. And then provision of ongoing education, including MP, PhD and NP, DNP levels, and specialized education. And I'll talk a little bit further about that in a minute. And then the fourth one would be those strong alliances with the governing bodies, for example, the Ontario Health Teams and Ministry of Health, etc. So if I look at recommendation 4.1, in this one, we draw attention to the need for an increased number of preceptors with protected time to support the learner. And to do this, my belief that we collectively need to engender a culture of preceptor-learner engagement in all healthcare environments. That is, as nurses, it is our privilege to have students work alongside us. To preceptor students, actually, it's part of our everyday and collective responsibility as nurses to do so. And students are the future of nursing, we know that. We need to ensure our ability to create a healthy and sustainable nursing workforce. Students are not guests in the placement environment, and I'm sorry we hear that a little bit too often. They are members of the healthcare teams, wherever that happens to be, acute care, long-term care, community, or public health. We need to work with our practice partners to build a team of NP preceptors who have protected time for student learning to achieve this goal. This is to support the learner to meet the nurse practitioner competencies, of course. Also, it also engages, it's an acculturation process for NPs in their role. Already nurses, now they're nurse practitioners. So recommendation 4.2, this is to attend to the geography of placements, and in particular to rural and remote, and the need for rural remote to be supported. So that support comes in the academic realm, that is to work to secure placements across rural and remote, and that government support student costs related to same. So for example, placements in northern communities. And I'll give you an example. For example, at Western, where I am, we have a huge catchment area from southwestern Ontario all the way up to Tobermory, and many of our placements actually happen in the rural and remote setting. Students should not have to incur that cost in any way. So that is, hopefully those students are going to be those people who go and work in those environments. So recommendation 4.3, that is excellence of practice within Indigenous communities. Underlining here that this means collaborating with Indigenous agencies, programs, and centers, as I said earlier, regarding how this work needs to be done. And of course, the embedding of key research-informed concepts in the curriculum. That is equity-oriented care. Research, by the way, that has been led by Canadian nurses. Here I'm referring to the intersecting concepts of trauma and violence-informed care, cultural safety, harm reduction, and contextually tailored approaches, i.e. respectful, non-judgmental engagement, whereby the MP understands and attends to some of the following things. So who are they? Who do they bring to practice? What are their assumptions, biases, worldviews, etc. that they bring? To understand and recognize power imbalance and to address it. There is a power imbalance between the practitioner and the client, whoever the client happens to be, whether that's an organization or an individual, and that they take a universal approach to violence. Anyone, anytime could have a violent history or be living with violence. They understand that structural violence and interpersonal violence intersect and have cumulative effects on people's health and well-being, and that violence is ongoing. It isn't suddenly over. So we live with structural violence, systemic racism, etc. So this is an anti-racism, anti-oppression stance. It really does put the onus on the NP to be critically self-reflexive. And we, as educators, need to prepare a practitioner who can do this. And lastly, under this piece, equity-oriented healthcare draws our attention to the need for transformational practice at both individual and systemic levels. So it's not just about individual one-to-one relationship. And then recommendation 4.4 is the ongoing continuing education and professional development needed to be able to do this important work. And that is to be community responsive, i.e. that there is a good fit between current practice and the healthcare trends. For example, being responsive to MAID, opioid use, populations that are marginalized by inequity. So here I'd also point to what we've learned from COVID-19, the need for MP specialized education in the areas of mental health, substance use, Indigenous health. And as you've said, Michelle, I think it's a really important point, retirement homes and long-term care, not just long-term care. So that whole continuum of care and need, and then the need to create more positions in those settings. So that's really, I just really want to underline that. Also attached to this, NP-led research that is clinically based and relevant, i.e. as Elissa noted, it's robust research led by NPs. And I think that's my recommendation. That's all I have to say for now.
Thank you so much, Vicki. Doris, I will pass it back to you now to speak to our recommendation about harmonizing NP compensation, please.
Thank you very much. I believe I am speaking on recommendation 5 and 6, right? The next two. Thank you so much. And you will see, I think one aspect that is important is that you will see how the recommendations flow very well. And you also will see, as you read later on the report, that we focus on what's now and being fully utilized. And we also focus on how to expand after, and that be then accompanied by the education, by the research, etc., and again, fully utilized. So that's very important, the current state and the next state of affairs, because we don't want a report that is, you know, just Fantasyland, where we only go to what's next step, but we don't focus that we have not achieved all the aspects on the current step. So we all the time we're looking with the tremendous task force about all the aspects, current and also next steps. Recommendation 5 tackles something that is dear and near to many NPs, and that has had an interesting trajectory for those of us that have been involved deeply in pushing the issue of compensation. So you will notice that we say harmonize upwards nurse practitioner compensation across all sectors and settings, because people like Eric and others that work in primary care will remember that actually the shortfall before was primary care. And we were talking about, let's fix the compensation in primary care. Well, we did. We fixed the compensation more or less, not all the way where we want to be, but better than what it was in primary care. And now when you look at colleagues in hospital care, now we have sometimes that hospitals are at a lower compensation than the colleagues in primary care or other settings in community care. So this is why we very purposefully chose the word about harmonizing upwards. Whatever the upward sector is at the time, we basically are saying that NPs, regardless of which sector, should be compensated fairly and across all sectors exactly the same. And not the same situation, by the way, is with RNs. And it doesn't serve at the end of the day the population. It does not serve the people of Ontario, because then you have nurses that work, for example, whether NPs or RNs, part-time in the community and more in the hospital because they're better compensated or they're afraid to lose the position. So we would like to see as much as possible, quite frankly, full-time employment for at least those that want full-time employment, with their compensation harmonized across the board. And that really is for governments to start to look at that regardless if NPs are unionized or not. This is not related to being unionized. This is related to being compensated fairly across the entire continuum. So that's government. For organizations and OHTs, in addition to that, we want to see benefit packets that are fair, because you know that now in primary care and in hospital care, NPs do have benefits, hope for the most, but in some other sectors, they may not. So we want that also to come to bear. And RNAO, of course, will continue to push on all the agendas. Side by side with pushing with full utilization and with pushing with expanded both utilization and scope, as you heard from my colleagues. I do want to echo Vicki, Victoria, Dr. Smye, because I do think that the role of NPs, as well as the role of all nurses, but NPs in particular, in the area of health equity is paramount, both to ensure that the population, the public, our communities get what they need. And quite frankly, if you look even from a strategic perspective and the branding of NPs, that is different than the branding of medicine. Yes, of course, NPs can diagnose and prescribe, etc. But let's make sure that NPs are absolutely aware of the SDGs. Let's ensure that NPs work upstream. And that's where I again want to mention the issue that I mentioned in passing by at the beginning about the role of NPs on Ontario health teams. That is a critical role that we all need to look. It's different than the role of NPs in public health sector, and it's different than the role of NPs in primary care. It's across all these sectors, and that role of NPs brings us also to not move the NP away from clinical practice, because nursing is a practice profession. Augment that role with policy, augment that role with administration, augment that role with health system surveillance, which is absolutely critical when you're talking about a person with the exquisite preparation that nurse practitioners have. I will move to 6 now, please. Recommendation 6 speaks about, and Dr. Smye referred to it briefly, I'm passing by, about the need for research to support nurse practitioners and improve health outcomes. Let me tell you, you all know of Alba Di Censo. I still hurt when I remember that when Alba Di Censo retired, she said, and I am for real retiring, and she did. And it is my view that although, yes, there are individuals that do research for nurse practitioners and other advanced roles, because Alba also did tremendous work for CNSs, we have a gap. We have a hole that we need to quickly fill in, because there is no time to be wasted. So this is where we are saying academic institutions need to promote, and Vicki referred to that, NP-led research, and ensure NP preparedness to also utilize and conduct research. Parallel that a bit with RNAO BPGs. Not RNAO develops the best practice guidelines. Others consume the best practice guidelines to ensure their practice is top. Their practice is evidence-based. And yes, we have a program that we train, etc., etc. Similarly here, we need NP-led research to produce new knowledge of the impact of NPs on clinical, health, and economic outcomes, especially with the formation of OHTs. And then we need NPs and others to consume that research, to use it, in other words, to implement, sustain, evaluate that new knowledge in the future. And we need to do that very, very quickly. And you will see that we speak about a research chair position, and RNAO will absolutely, I'm already looking into that, secure funding for an NP and CNA research position located at RNAO. That should come as no surprise to you. And a research chair that will lead the nursing profession on the role of NPs in research for the population. I want to tell you why it is at RNAO. There is a unspoken tension in some courts, sometimes more than what I would like to see it, and more than what many of my colleagues would like to see it, between the differentiation between NPs and RNs and RPNs. That type of dichotomy should not exist in nursing. We are one profession with individuals and practitioners in different roles that have different levels of expertise. And that is absolutely critical. And probably, and people like Michelle and others would be able to comment during the discussion, that's perhaps where the DNP role differs from the traditional, researcher, that it brings closer all the practicing elements of nursing. To have a research chair for NP and CNS knowledge discovery and knowledge utilization at RNAO will mean also to kind of close these gaps that create tension rather than leveraging on the profession as a whole for the sake of Ontarians and not only Ontarians, Canadians and others. So we are looking into this. We will get there. Trust me, it will be announced before probably you sneeze. And it will be located at RNAO, and at the time we will actually issue a call for top people to apply to become that first inaugural research chair. Organizations and OHTs also need to protect time for the NP-led research. I had the privilege of co-leading the attending NP role with then Chief Nurse Officer, Dr. Deborah Barnes. And this is after our RNAO's conversations with Premier McGuinty and actually the launch of the attending NP by Minister Deb Matthews. When we did that, when we did the task force, we segmented time. We segmented time for research for the NP. We segmented time for mentoring for the NP. We need to make sure though that organizations and OHTs, and you will see that in all the recommendations we are including OHTs because we start from the position that we absolutely assume and will ensure that NPs will be part of the OHTs across the continuum of care because that's necessary to ensure timely access to safe and quality services across the continuum of care, which is what OHTs are. So we need to ensure all of you that work, whether it's in sectors or whether you work in OHTs, whether you work at the ministry or whether you work at RNAO or whether you work in an academic site, we all hear from nurse practitioners in clinical settings, and this is what we are talking here. We need to make sure that they are protected at least in a 20% for research activities. In the case of nurse practitioners in clinical settings, could be to participate in NP-led research by academic institutions or by the soon-to-be research chair, or to consume, to transform that research new knowledge into uptake of that evidence and sustainability of that evidence, and also closing the cycle or the circle with evaluation of that evidence. So that's for recommendation 6, and I will pass it back to Catherine.
Thank you so much, Doris. Beth Sweeney, if you could please speak to recommendation 7. Beth, you're on mute.
Thank you very much, Catherine. It's been a real treat being part of this task force up to this date. This was the accumulation of all of our work, and it's sad that we can't be in person, in bodily person, but this Zoom has, I know how much work it has been for you at the RNAO, Catherine and Jean and Doris, and I thank you from the bottom of my heart for putting this together, because it's such a treat scrolling through and seeing everybody's happy faces. So my portion, recommendation 7 about broad and insurance coverage, is going to be a little bit more nitty gritty and specific. So to be very, to give the history, insurance companies have had physicians as the prescribers and the persons who are getting paid in their policies for 100 years now, okay? And as you know, our legislation has caught up, and all of a sudden we recognized that we couldn't order an orthotic. We can order our opioids, but we couldn't, our prescription for an orthotic was getting refused. So this is where this recommendation came in. There was an action with respect to sending letters to employers to change the notion that we as NPs should be part of the policy. However, we at RNAO decided to go deeper, go to the carrier itself. So all of the carriers that you'll be hearing about know about our task force. They're working with me, and through Hub, our RNAO insurance carrier, know that we as nurse practitioners and part of this task force wish to champion them. So if you want to get out a pen and paper, this is an ongoing process. And I am here for you for long term, and I look forward to the comments when we're going further on. But let's just say I'm going to start with a champion and end with a champion, and we've got a few in the middle that we're all going to be aware about and still need to work with them, okay? So number one, I just want to say Blue Cross has been a fantastic advocate for nurse practitioners right from the get-go. I would like to hear from any nurse practitioner across the province if ever they've had a problem with Blue Cross, because I hear from them and no one else and colleagues, when I check in on our social media platforms, have let me know that there has been any problem with Blue Cross. So from our standpoint, Blue Cross is a thumbs up, and we're so proud of that. Equitable Life, that is one that's, and some of you, by the way, might not have even heard of some of these insurance companies. That's okay. I still want you to keep them in our radar because they're out there. They are, and let me go back to say that all of the insurance companies that we're dealing with are 100% fine with nurse practitioners ordering prescriptions. That is within our scope, and for some reason, all insurance companies have allowed that without a glitch. However, when I speak, as I said, right now about Equitable Life, they said only orthotics at this point cannot be allowed by a nurse practitioner. Either a physician, chiropodist, or podiatrist are the only ones to order orthotics, okay? They are open to the change, but they haven't made the change in policy on paper yet. And this is where I'm going, yet. Industrial Alliance. It is, they say, if ever an issue with any of the medical treatments, then it would be up to the employer and the carrier to adjust their practice. But they, Industrial Alliance, are 100% supportive of the nurse practitioner and what we can do in the future. I'm going to go on to Empire Life. All of the braces and splints, etc. They have no issues, and as far as we can see, have no issues with Empire Life. I'm going to go on to Manulife. They also are very supportive of nurse practitioners. But they said, if there's any glitches, they're so supportive. They said, if there's any glitches, please, like, I have the name of the person who's responsible, and they literally want to make that change. They're like, Beth, have yourself or your nurse practitioner, let's make that change. We're interested in going forward. If there's any orthotic or prescriptive restriction, then we need to work on that with the carrier and the employer. Second last I'm going to mention is Great West Life, which is now called Canada Life. And this, unfortunately, nurse practitioner colleagues, is a thorn in our sides. It's a huge waste of time when we, as the primary care provider, make a diagnosis, prescribe a treatment, write a prescription, and then get denied. The patient gets denied, has to come back to the office. It requests a physician only. So this Canada Life is a giant company. As you know, Sun Life, giant company. We wanted to work with those two companies to be really sure that we can get them on board and have the changes in the policy strict. No more nurse practitioners having to write letters, and we need it done at the base. So we were very, very dismayed when they changed their mind, literally changed their mind to myself, with Jean, with Catherine, with Doris, on a telephone call on July 23rd. They know that we are pronouncing today that we are very discouraged by their lack of ability, their lack of moving forward to change their policy from right now, all of the words only say physician, and they said they would in 2021 change every policy, that they would take the entire year. But unfortunately, they decided that they were going to renege. So this is important for us as nurse practitioners to know that Canada Life literally said to us that they're not committed to that change. But now I need to let you know that Sun Life is a giant champion. I'm making this announcement today, right now, as a giant announcement, that they are committed to changing every single policy to allow nurse practitioners to be 100% able to write and be covered. That is going to happen, everybody, on December 1st. So if anybody's having any issues until December 1st, come back to me. We'll get it I'll get it connected with the actual person that's making the issue. It's probably the reality that the lingo from 100 years ago was physician only. Okay, so that's the reality. And going back to the soreness, I mean, of Canada Life not taking us on and changing that policy. Yes, it's a monetary thing. They said, yes, you've got more nurse practitioners in the system. Yes, we're going to have more costs. No, we cannot accommodate that. That is a really sad day for us with them. But what can we do as a group? We have to celebrate Sun Life. If we can motivate our patients and all these other companies, but motivate, you know, when our companies, when the places that we work for go with large corporations, we have to celebrate the fact that Sun Life and Blue Cross and these other smaller companies are committed to the scope and the role, the knowledge, the expertise of the primary healthcare nurse practitioner. So thank you for being part of that announcement. And as I say, if ever you come into issues, please come back. I'm very vocal in social media. You'll see me, Beth Sweeney, as part of the NPIG Facebook group, and I'm cross-posting all the time about RNAO events, RNAO policy, And I'm here for questions and I'm here for comments. One more thing before I finish up, if you don't mind, is about ADP forms. And we're coming along. It's great. You're going to see the fact that the actual forms themselves have changed from physician only to having nurse practitioner added into the forms, which is a very costly thing for paperwork to do, and it's happening. One thing that has not happened is ADP forms for hearing aids, and I need to hear about that. I'm hearing from the companies that they are so frustrated that nurse practitioners cannot get the coverage for the hearing aids, and that it's getting sent back, and that the doctor has to be the one to sign the form. And we all know about those issues and the patients being put to the bottom. So with your blessing, I'm going to move forward with that with you, Doris and RNAO. And again, I need to hear from all of you.
Catherine, if I can make a comment, please.
Yes, absolutely, Doris.
First of all, I want to recognize Beth's role. It is very important when you have an issue that is this difficult and this sticky, quite frankly, to have a person dedicated to it, specifically to it, and be focused on it and pushing, developing the relationship, etc. I think that the overall message from Beth, you absolutely need to take note and act on it. One is to let her know anytime you have difficulty, what's the difficulty? Of course, not the patient. What's the difficulty? What's the company? Second, you absolutely need to know that we communicated in no uncertain terms that RNAO will publicly celebrate those insurance companies that are working with NPs to serve Ontarians. We will work with companies publicly that serve Ontarians because it helps them simply to have access and have good care. And also, quite frankly, it saves money to the system because otherwise you're delaying treatment. On the flip side, we will openly shame, and I don't shy away of that, shame companies that are determined for the wrong reasons, in fact, and we know them because we met with them, to not work with NPs. So we need you with boots in the ground to tell Beth, where do you find hurdles? Give it as many examples as possible, because we will continue to march on this. Not a single company, not a single insurance company that accepts reimbursement for physicians or other health professionals is in their right to refuse nurse practitioners, because at the end it's the client that suffers. It's the Ontarian, the person in Ontario, or for that matter in other jurisdictions that suffer. And as you know, many of these companies are multinationals. So that's the other aspect, Elissa, that we need to look. The companies that are giving us travel here, are they actually recognizing NPs in, for example, the US? Not to be discussed now, but Beth, that will be an important conversation, because these companies, for the most, are multinational. So I wanted to leave us with those thoughts, Catherine. And I also want to thank, we have thanked a lot of people, including all of the task force. And we have thanked, of course, Catherine, and I've thanked Irma Jean that also helped. I also want to thank Lorraine, that has been behind the scene, helping with the promotion, helping with the getting your bios, etc. And today also specifically Anne-Marie, Erica, and PG that are helping with the Zoom rooms, etc., etc., etc. So I just didn't want to forget that. Thank you, Catherine.
Of course. Thank you, Doris. We're going to move on to recommendation 8, our final recommendation from the task force report. And this is in regards to showcasing impact. So I will be pleased to pass it on to Barbara now. Thank you.
Thanks so much, Catherine, and greetings to all of you. Thank you for inviting me to join you as an outsider to this task force. But I'm very honoured to do it, and I'm particularly honoured because we've loved working with RNAO. They've been, you guys have been wonderful collaborators, and Doris, it's been a real honour to work with you. And we've never actually met, Doris and I. This is a treat.
We are joined by the hip and never met.
No, we've never met. And we're going to have such a big dinner after the pandemic's over. So it's a great pleasure to be allowed to be in this meeting. And I want to sort of, when talking about this recommendation, it's one that actually is very close to my heart because I am the executive director of the Global Nursing Now campaign. And what we, of course, are is an advocacy campaign. And we have been trying to influence both the public perception of nursing and also the political perception of nursing around the world. So I have some very strong feelings about this. Now, let me just start by talking about the State of the World's Nursing report that was published this year, which you all have by your beds, don't you?
Yes, I do.
Of course, Doris. I'm sure Doris actually does. But, you know, the thing about the State of the World's Nursing Report is that it's the first one that WHO have ever done.
Yeah.
Ever. And this is a huge opportunity for nursing around the world. And this is the context into which your important task force is arriving with these recommendations. You have done a wonderful review of evidence and identified actions to do with nurse practitioner practice, which is a subject I love. I feel like I'm with my people at the moment, my nurse practitioner people here. I love this. This has been the subject of my own research when I was in the research world, and a subject, you know, getting advanced nursing practice into the workforce that I was passionate about at WHO and at IntraHealth, because I know that advanced nursing practice can actually change the face of healthcare around the world. I know it can, because we have the evidence. What we don't have is the way of making that evidence engaging, if you like, for politicians and policymakers. They don't stop and listen to it. So we're not top of mind when it comes to looking at policies for the future. And, you know, the public, I had a message because of my position here in England. I've sort of had some visibility in the nursing community or the healthcare community. And I had a message from a woman who was a woman I looked after, let me see, has got to be 35 years ago. I have no recollection of this woman, but she found me on Facebook through Nursing Now, and she messaged me and she said, "Are you the Barbara Stillwell who was a nurse practitioner in Birmingham in the Midlands, blah, blah?" And I wrote back and said, "Yes, I am." And she wrote back to me and said, "Well, I just want to tell you that you changed my life." Wow. I never knew, she said, that it was possible to go to primary healthcare and talk to somebody about what was really my problem. And that's what you allowed me to do. And, you know, I was absolutely bowled over, you can imagine, by this. But, you know, it's what we find so difficult, isn't it? I can tell you that story, but if I go and tell Matt Hancock, who is our Minister of Health here, he'll forget it. When I walk out of the room, he's forgotten it. And I need to find a way, as we all do, find the language that will make him stop Matt Hancock or anybody else of these, you know, ministers of health. It will make them stop and not think, oh, another nursing story. Oh, da, 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 da. But what they, you know, what we need to have them think is this has benefits. Nursing is a best buy in health for all the reasons that we know it's a best buy. It's a best buy because we're at every stage of the care continuum. It's a best buy because we can help people deal with what they're tackling, because we can help educate them, because we can help them stay well, because we know that people who are being cared for in hospital that have good nursing, well-educated nurses, stay out of hospital longer. You know, these are the things that we know, but we have to find a really impactful way of making that knowledge available outside of nursing. We are completely brilliant at talking to each other. It's so wonderful, but you know, we are just not so good at talking outside nursing, unless your name is Doris. If your name is Doris, I think people tend to listen to you. But Doris, you need to show us, you know, the rest of us, how do we engage these folks? And we know that some of the tricks are, you know, getting to know people, being strategic, placing our message in a context that's interesting for everybody who's listening to it. And for the last 9 months, that context has been the pandemic. And people have listened because they've had to, because it's been life and death. So they have listened. But what we now need so badly is to grasp this superhero image and move it along and say, okay, you need to listen to us because this is what we can offer you. And we need to find a way of doing that. And I would suggest we need to find a way of doing it outside nursing with people who sell things we can't live without, people who made me remember that beans means Heinz, which was an advertising slogan from when I was a child. And I can still remember it, beans means Heinz. And we need to say, you know, what do beans mean for nursing? We've got to have that. We've got to have those catchy hooks that both the public and the politicians will not forget when it comes to policy. So that's my message. That's my rah to you. And in a little while, I also want to engage you in some deeper thoughts, I think, about why we're here, you know, why we're where we are.
I would like Catherine for a second to make a comment. First to thank Barbara. We have not, I want to correct for people, we have not met in person. We have met many times now in Zoom. And I want to thank, not congratulate, thank Barbara and Lord Nigel, but the doer is the Barbara, for the strength that Nursing Now has brought to nursing in the world. I don't know of any other initiative globally that has ever brought this glueness to nursing that we see now. And some time ago, talking with Barbara, we discovered that we have one thing in common, one yet more thing in common, which is the love for social movements. And this is what Barbara and her team, which is tiny, you need to know, tiny, has created for the world. So thank you, Barbara. And you don't know the end of us yet, because I was supposed to call you on the weekend with yet one more thing that you will be thrilled, that will help your work. And I will do that. I just didn't have a minute to breathe because of the media. I also want to say, I love this nursing is the best buy in healthcare, and how we transform that for politicians, because the public is there. The public needs to know nursing is the best buy because it gives me rapid access to good care and quality care, and NPs in particular can prescribe and all of that. They still, some of them think it's only doctors, right? But how do we bring it now from an economic perspective? And Michelle and others spoke about that, from the economic perspective to the health system as a whole. That will be our last session. Our last session will be discussions, and we will then take it back, and we will work with Barbara from a Nursing Now perspective, and Elissa from ICN perspective, and others, to really make sure that it doesn't only serve Ontarians, but serves the bigger world. Because if it serves the bigger world, will serve also Ontarians. The last thought I want you to leave with you to reflect, because it will affect what we can do, is the ongoing conundrum, and I had it this weekend again and again and again, of nurses that not only feel, but have been made to sign that they cannot speak with the media. It's heartbreaking here in Canada and in Ontario in particular, because doctors are free agents. They don't report to an organization. They're not employees. And therefore you see doctors here, and I'm not talking about epidemiologists, any other doctor, here, there. Nurses, they need to go through hula hoops, and then only one gets permission to speak. So we will need to tackle those issues if we want to really be in the dinner table of everybody, and we must. So thank you, Barbara, because you deserve huge kudos for, and I was thinking as you were speaking, you gave a few beans. Maybe you will want to be the first chair, research chair, there I say. Here you go, Barbara. You did a lot of research with WHO on this. I'm just saying it, but we would love to have you in Canada.
Oh, I'd love to come to Canada. That's my goal. We love Canada.
Okay, so now back to you, Catherine. Meanwhile that you put the slide, I can tell you about one important colleague, Afaf Melis, that lives in the US in Pennsylvania, that didn't threaten me, but said to me that if President Trump gets elected again, can I open a job for her here in Ontario? Well, we didn't gain her because luckily Biden got in, but maybe we can do some trick for you, Barbara, and get you here. Okay, back to you, Catherine.
Thank you so much, Barbara. Your enthusiasm is very contagious and setting the stage for a great day and a great discussion later. So in the interest of time, we'll move on now. The session is set to end at 11:15 and we'd like to get to some questions. I just wanted to share with you all a photo of some of the task force members that were able to come into home office in February and work on the recommendations and report together. So we're going to move on now to questions. I did notice in the chat there is a lot of really lively discussion, so thank you to all who have shared some questions, comments, and concerns. I think we would like to start with Beth. There was some questions about different insurance companies and what they have been allowing NPs to do. And as well, Beth, I believe you wanted to give an update with regards to medication samples, so I'll let you do that now.
Yes, thank you. So thank you for all of your comments. And literally anything that's mentioned about Sun Life, I will be replying to my Sun Life connection and saying, like, in congratulations to them making the change and that we're celebrating them. And I'll probably ask for the blessing for Catherine and Doris to maybe go into the next RNAO journal to announce this and celebrate them. But also, I will be mentioning that these are specifics that our colleagues, my colleagues, have been having issues with, and to make sure by December 1st that these specifics, as you've told me in the comments, are completely clear and free. So no more compression stocking issues. Oh my God, such a frustration. Okay, on to medication samples. So July 1st, 2020, Bill C4 put in amendments. So I guess you haven't had them yet, but I've just had like amazing emails. I just wrote a little note in my work email. I'm getting notes directly to me from GSK, Boehringer Ingelheim, to say, here is your link, how to order online samples. Okay, so they had all the pharmaceutical companies can now provide samples to us as NPs. And thank you, Michelle, for sending the link from the College of Nurses on our responsibility of how to accept those samples. And so that's in the comments. Thank you, Michelle. And the reality is that with this COVID issue, that is present and was very much unfortunate for the pharmaceutical companies come July 1st, that they aren't coming to our office. And so that's why perhaps you didn't know about it. So this is amazing news. Yes, Nancy, it's amazing news. And so will we be able to order online with the online, the names of there's 2 online kind of specific medication sample sites right now. If anyone remembers them, throw it in. Physicians Online, thanks, Nancy. And I think there's one more. So that just made me remember that I haven't gone on those sites to see if I, as a nurse practitioner, can order from those sites. If we cannot, that will be taken care of as well. I tried in August to do so, and I could not. And Doris, I drafted that letter of action to you. And oh goodness, there's other things on your plate, but I haven't tried in November. So let me do that first, Doris, and then we can talk.
Very good.
Thank you so much, Beth. Now
Keep
we're going to move on.
coming.
Yes, sorry, I didn't hear you. I spoke over you. I'm sorry.
I want the questions to keep coming.
Oh, good.
And thank you, Jean, for posting my RNAO email. It's beth.sweeney@rnao.ca. But if everyone can please make sure that they're part of our NPIG Facebook group, we're a private group, and your questions or your comments are things that everybody will want to hear. Everyone is learning from this dialogue. So a private email to me is not actually what I would prefer. I would prefer our dialogue to be in our private NPIG Facebook group. Okay, so if anybody has not asked or requested to be part of that, it's myself and Hoodoo that are the administrators. Let's keep on communicating through this venue, and or I will put up the Facebook link as well. That's what I'll do for sure in the comments. Thank you, Catherine.
Thank you so much, Beth. I'd like to now turn some questions to Vicki. During your talk, Vicki, there were a couple of NPs who commented that they struggle to find time to actually do precepting for students. And I'm wondering if you can comment on any strategies that NPs who are interested in precepting students can use when trying to negotiate time in their role with their employer to actually allow them the protected time to do such important work.
Right. So I saw the comments and I really appreciate it. And I think that's the recommendation around protected time, because this is something that's been problematic both in the research sphere as well as in terms of preceptors. And I have a real passion for the research part of that as well, because it has come to my attention through our practice partners that they have not been able to get protected time for their MPs within their institutions. So it is a problem. But anyway, I think some of the people did suggest ways that they have accessed other preceptors, people that might have time, and actually, you know, to have an opportunity to work within the interprofessional team, so in an interprofessional kind of way. And I think that's one of the ways to go as well. So, you know, we kind of COVID-19 did something for us, at least in the Ontario Primary Healthcare Nurse Practitioner group. It used to be called Coupon, that where I think Beth, that's where you did your work, but your NP. We are actually looking at multiple ways for MPs to get preceptors, and we found that not only that they actually found some preceptors in acute care, even though primary healthcare nurse practitioner program that worked really, really well. We were surprised actually. So I'm not recommending that we go that route completely, of course, but there's lots of places for preceptorship opportunities that we've had to think about quite differently. Also, we met with our colleagues in British Columbia, who also have a little bit different model around preceptorships, and they moved to a lot of virtual because they do a lot of telehealth, etc. there, and do some shadowing with physicians. Again, this isn't it's not about the model, it's about opportunities to do things a little differently when we're pressed for preceptorships, and those have worked very, very well for that group of family nurse practitioners. So there's no easy answer for this, but I think protected time is the essence of the recommendation, that we and that we look outside the box to what are the goals of the nurse practitioners actually coming into the practice? That is the student, because they're different. Some want to have more administrative roles, some want to have, so that we're looking at the nurse practitioner role a little more broadly, and that we offer preceptors more broadly, understanding that they also have to meet their competencies, of course. So I hope that's helpful.
I would like to add to that, Vicki, just a couple of comments. So the good news is that your role description at least has that, because we actually put it there. The bad news is that, yeah, role descriptions can say anything, and if there is. On the other side, I want to tell you about our colleagues in medicine, okay? And those of you that are involved in social media will know this. Colleagues in medicine don't get paid for doing research, nor do they get paid during the pandemic to collect data and put it to the benefit of everybody. They do it, quite frankly, in addition to their regular work. Whether I speak about Jennifer Kwan, who every day posts data about what's happening with COVID, or whether it's Nathan Stoll, who every day puts data about what's happening specific to long-term care, or the many articles that he and others have published. This is not to say, guys, suck it in and do it. But in a sense, it is, let's get going, even if we don't get the time, because I doubt that we ever will get the amount of time that is necessary to do good research. And some of us can tell you that book of, I think, is 500 pages or whatever, whether it's Imagine, myself, or many of the authors, it was done on weekends and nights. So I'm not saying everybody can do it, but at the end of the day, if we will wait for every NP to have protected time, I think that Victoria, I, or any one of us will be telling things that likely will not happen. Hopefully those in academia at least can get the time. This is why we're going also after the chair for research, but people in practice, or clinical practice I'm talking, or administrative practice, always their time is being eaten away. I remember my time as a clinician, staff nurse or CNS. I remember my time as administrator in hospital settings. I was. Never was time, and always. I'm not saying it's good, okay? Please don't take it as I think it's ideal. It's not. But we cannot wait. We need some of you, whether because your kids now are older, or because you can dedicate more time, or because your work gives you flexibility, whatever is the reason, let's please get on in moving research, and equally important, utilizing research. And it's the last time I'm going to mention Arik, not Eric. It's the last time, I promise, because if not, I will be someone will tell me in the, but he's kind of one of the people that came to RNAO as a nursing student, and he has grown with us, and you saw him with a baby. 4 kids this guy has. He's doing a PhD and he's working full time. So I'm not saying it's easy for him. It's not easy for anybody. But you know what I call it, and you have seen some of my tweets on that, I call it dreaming the Nightingale dream. Eric is one of those people, and there are many Erics that are dreaming, that are living the Nightingale dream, where Nightingale also was busy to the ñañas, but in addition to being busy to the ñañas, she was inserted in here, inserted in here, inserted in here. That's what we need to do, guys. We don't have time to wait. We will try to get you protection. We will get a chair, but let's, those of us that can, get going, because no one is waiting for us on the other side of the equation, if you know what I mean.
Thank you so much, Doris. Michelle, I'm wondering if you can speak a little bit to the DNP program, as you are one of our panelists that does have a DNP yourself, and as well to the inaugural DNP program that will be introduced in Ontario.
Sure, thank you very much, by the way, to the panel today and the task force members. I was busy watching the chat while multitasking, as we always do with nurses, and I did put a few links in there, by the way. There was questions about the OHIP bulletin. There was questions about ADP. I put a link on to the programs at University of Toronto and Athabasca. In terms of your career trajectory, as you move along Maslow's hierarchy of needs, and as professionals, you really need to think where your self-actualization is at. You know, I'm diploma to doctorate, bedside to boardroom to bureaucrat. And I really think we need to think about nurse practitioners and sectors and systems thinking. We talked about all the sectors, but what we didn't talk about are models of care. So if I want, and I'm a DNP as well, but if I want to be in pure academia, we need to set up a system that I can practice and maintain my nurse practitioner registration as well, and what these actual nuances look like as we do knowledge transfer and translation across the systems and contribute to meaningful advanced practice information as well. If you choose a DN or a PhD, you choose what's best for you. What we need to get through is the messaging. Doctoral prepared nurses we need to think about for health workforce planning. It's not, again, about a PhD versus a DNP. It's about collective wisdom, collective momentum, and that social movement, and more importantly, how we leverage our doctoral credentials and how we ensure that we're utilizing them to ensure public awareness and role clarity as well. I chose a DNP because I really identify as a clinician. I still feel that imposter syndrome, and I'm the Provincial Chief Nursing Officer. I'm in postdoctoral systems things, and I always just want to learn. I have a huge thirst for knowledge. And for example, I just finished my mental health and addictions CAMH certificate and prescribing and concurrent disorders. I'm always thirsty to learn. I like the leadership lens of it. I like the health equity and health literacy lens of it, and that identified with me. I continue to practice still as a clinician. So I chose that route, but if you're thinking a PhD or a DN, you need to choose what works for you, and more importantly, how you be flexible. You know, Doris talked about Eric, and many of us, we're working full time, or students. We have other family responsibilities, but it doesn't feel like work if it's actually your passion, and your passion is nursing. So I would, you know, urge you to think about that moving forward. And when you talk about what you do, we're not as strong as showcasing what we do. Even that protected non-clinical dimensions of time, we need to showcase of what that is so that people can see our contributions and how we're contributing to knowledge, the depth and breadth and translation across our systems. Doris, I saw your hand while I was talking.
Yes, I was clapping.
Oh, sorry.
I was clapping because you were mentioning none of us has a lot of time, and I understand not everybody can, but take Darcita Versale, take Corsita. Corsita is the co-chair of the Black Nurses Anti-Discrimination Task Force with Angela Cooper. Big job, guys. Dara, she also has a big job, and you know, some contribute in a task force, like all of you are, and some contribute in a research, and some contribute in translating that research into practice. We all need to pitch in, because I think Michelle will concur with me. No one is going to wait for us.
Be the leader, be authentic, be courageous, and make a difference and catapult yourself into what is meaningful, purposeful, and deliberate for yourselves and the greater good of the nursing profession to help serve Ontarians and the health of the world.
Thank you so much, Michelle. So we're at 11:17 a.m. now, and we do want to make sure that everyone has a chance to stretch their legs a bit before we move on to our next session at 11:30. So in the interest of time, I will ask our speakers to give just a quick recap, any final thoughts before we move on to the evaluation. And we'll start with Vicki, please.
Yeah, so just a couple of thoughts, because I know we're a little bit pressed for time. So one of them was the importance for me of the task force document being a living document. So I just see all these comments coming in. I see some really great ideas, etc. So informed in an ongoing way, just like the RNAO best practice guidelines, which have always been fantastic in this regard. And so I would suggest that, and being informed by things like the pandemic, which is not over, and BIPOC and other movements, Black Lives Matters, etc., so that we are current and that we're meeting current need, etc. And then the other part is just to underline one of your comments, I think, Doris, for me, is the importance of intra and interprofessional liaison. So, you know, nurses working with nurses, including the clinical nurse specialist, and that force, that leadership force, when it comes together, is a power to be reckoned with. I believe it is going to lead transformative change in this country in healthcare. And for me, it's also about looking across the spheres of influence. So, you know, having impact on nursing outcomes, on patient outcomes, and organizational and system outcomes. So that we need the collective workforce in order to do that in nursing. So I think the advanced practice role is where it's at. I'm a big supporter of NP practice. As you know, I do chair the consortium, and I actually really believe this is a way forward for us to really push this practice. And again, pointing to those 25 NP-led clinics, highly successful and very important in practice. And then I just want to underline the research piece as well. I am a researcher, so of course, that's where my passion is as well. And I say, you know, alongside other nurse researchers, but also NP-led, I again want to underline that, because you're on the front where things are happening and where the questions need to be asked and answered. So I just want to say those things. It's been very exciting being part of the task force. And I agree with you, Doris, absolutely, about, you know, ongoing education. And it is our responsibility to do that as a profession. So I really think that's important. So thanks very much for inviting me.
Thank you so much, Vicki. Beth, if you have any final comments on the insurance piece, we would love to hear them, please.
I would just like to say thank you. It's an ongoing venture, and I'm here for you, with you, and continue to communicate. Thank you.
Thank you, Beth. Michelle? You're on mute, Michelle. Not working? Okay, why don't we pass it on then to Elissa. Elissa, do you have any last comments for us before we wrap up?
Hi. Oh, I don't know. Hold on. Trying to start my camera up again. Oh, there we go. I was so interesting listening to all of the recommendations from everyone's different context. So I really appreciated that. The one thing I did want to kind of bring up that was so interesting to me, and I believe it was Beth that was bringing up the issue about samples. And about NPs being able to sign for samples. I just wanted to maybe offer a perspective on that, because there's been a lot of movement around the world, different, especially in areas with kind of more highly evolved NP practices, about the interface of pharmaceutical companies and prescribers. And we know that pharmaceutical companies use samples as marketing tools. So they use samples to get you to prescribe a drug, to get people to keep taking drugs. And mostly the drugs that are sampled are more expensive drugs. This has become a huge issue here in our country because everything is very expensive. But it's really a catch-22 in a sense, because you want to give free medicine to your patient, but on the other hand, you don't want your patients to have to spend a lot of money on drugs or cost your healthcare system a lot of money. So I don't know, just that's a different context. There's a lot been done about this in Australia, and especially the interface between the industry, pharmaceutical industry, and nurses just in general. So just wanted to put that out there. Thank you.
Thank you so much, Elissa. Barbara, over to you for some closing comments.
It's been wonderful to listen to this report. It's an important report and it's robust. It's got good evidence in it. It's been carefully thought out with good recommendations. Please, please consider how you can share it with the world. Because everywhere, everybody's looking at advanced nursing practice. It's the next logical step to make healthcare universally available. Please think about how you can share this report and what you learn from implementing it. So I would say, take the report and be disruptive. As disruptive as you possibly can be.
I want to take a second to thank everyone. You know, every time I listen to any of the task force members, and in particular today to the panel, it's just such rich discussion, such a wonderful feast of opportunities. And I think that we are on to something here. And especially not only for Ontario, but with the connections with Elissa and with the connections with Barbara, we may be revolutionizing and being disruptors for the world, Barbara, more than what you want even. That will be the day, more than what you want, that will be the day. So kudos to everybody, and let's keep going. Let's keep going. Amazing contributions from every panelist, all of you, Vicki, Michelle, each single one of you, Beth, all of you. Thank you.
Thank you so much, Doris, and everyone who has joined us today, both on the panel and who's here in participation to join us in the knowledge exchange and just to move all of these really important issues forward. So we are going to conclude this first session of the day, and we're going to ask you to please participate in a polling session.